Thank you, Ziad. Thank you, Ziad. Good afternoon again. So my next 10 or 15 minutes, I'll be talking about pertussis, the disease, the vaccine. I will touch some base on the resurgence debate around the world, and some, if I have time, strategies to interrupt transmission of this disease. Again, I showed you this in the morning. Bordetella pertussis is a neat gram-negative pleomorphic cocobacilli that was characterized by the Belgian scientist Jules Bordet. It has several characteristics, some adhesions and toxins that are very important in characterizing the bug or making the vaccine, including the adhesions filamentous hemagglutinin, fimbriated antigens, pertactin, which is called BRN, and this is very important, and the other toxins like pertussis toxins, adenylate cyclase, tracheal cytotoxic. And let's remember that cell-mediated immunity might be more crucial in developing immunity for this bug than the human immunity. Very importantly, even infection from original microorganism does not give lifelong immunity. It gives about 4 to 10 years. So let's start from the beginning. Do not expect immunity from vaccines more than expect immunity from the disease itself. So it is called fastidious. It is very difficult to grow. And again, it is a human-only pathogens, and we need a special media. And when you want to grow this bug, you need to tell the lab that you're looking for Bordetella pertussis. This is very important. When we talk about epidemiology, it remains an endemic disease, despite very efficacious vaccines that are used for many countries now. It remains as an endemic disease globally, but much, much lower rates compared with the pre-vaccine area. It was introduced in the 1940s, the first vaccine. And the evidence that a resurgence in some countries now, this is a debate, this is just a statement, there is some evidence that resurgence in some countries using the Acellular vaccine despite high levels of infant pertussis vaccination coverage. And this is still a debate also. Usually outbreaks happens every 3 to 4 years, of course on top of a baseline endemicity that might be different from area to area, with, interestingly enough, no significant seasonality. It goes all around the year, and it is very highly contagious. The basic reproductive number, the R0 or RO number, is about 12 to 17, which is really higher than many other viruses or bacteria. Look at the global mortality. As I said in the morning, we debate about vaccines, cellular, not cellular, but we use the vaccines, whether both cellular or acellular, and the mortality is going down. In 1999, it was estimated that mortality is about 259,000, went down to 195, and nowadays the last estimates in 2015 was 54,000 deaths a year. So very tremendous improvement in mortality secondary to pertussis. What's interestingly enough, this is a article from Melinda and Bill Gates Foundation. This is from the data they have. They found that the numbers of under 5 pertussis diseases by WHO regions, if you look around here, this is 53,000 deaths. Most of them were in Africa. 31,000, they are in Africa. And in Middle East, for example, there are about 10,000 deaths. In Americas, only 1,300 deaths. Very importantly, that there is a lot of deaths are occurring in the first few months of life. And this is very important to understand about pertussis disease. This is a very nice picture showing since the introduction of the vaccines in the 1940s, how much reported cases of deaths, then it went down, down, down. Then there was the introduction of the AB vaccine in the 1990s, is still going down. Well, the only thing I want to show this slide that look at the effect of vaccines. It's very, very nice effect. However, if you look deeper, and we'll talk about this, you will see these swings here, and more swings now in the last few years with the resurgence of pertussis disease. Okay, again, this is recent epidemiology from the States, infants and toddlers pertussis incidence. This is incidence of the disease, and the incidence is very much more in less than 6 months of life, where most of the mortality can happen actually because of the situation there. So, and then you see almost similar incidence in the other age group. So again, less than 6 months of age, even in a developed country like United States of America. So the history says that since 1940s we have a very effective vaccine, which is the whole cell vaccine, and it decreased the burden very much. However, when we start seeing the effects of vaccines, less mortality, we start thinking of other things like adverse events. So it causes a high fever, the whole cell vaccines, 1 in 100 vaccinee. It causes a high pitch, inconsolable crying, again in 1 in 100. Seizures can happen with fever. And the most frightening thing is hypotonic hyperresponsiveness syndrome, which can happen in 1 in 1,000 or 2,000 vaccinees. And this is 1 per 100 or 1 per 2,000 is not a small number actually, especially when you talk about developed countries, when the uptake of vaccine concept can be affected so much by the level of adverse events. So companies started to make acellular pertussis vaccine, and you could see these are just examples of acellular pertussis vaccine, starting from the triple vaccine, DT, AP, or the vaccines that contain 4 vaccines like IPV, or 5 or 6 vaccines. So we have a complete array of combinations that you can choose from or replace with. And of course we have the adult or adolescent vaccines with the reduced pertussis content, which are TDAB, and the other TDAB, the Adacel and Bostrex. So we have many vaccines around, not like cholera or leishmaniasis or other thing. This is the 2018, the US recommendation for vaccinating of American kids. And if you can look here, where's the diphtheria, there are 3 doses, 1, 2, 3, 2, 4, and 6, followed by a 4th dose in the 2nd year of life, and another dose between the 4 and 6 years of life. This is for, of course, with other vaccines. And if you look here, this is for adolescent, and 1 dose of TDAB between 11 and 12 years. This is the official recommendation by the ACIP in the States. Okay. Now, in the Middle East, these are the countries that are using the acellular vaccine, including Bahrain, Iraq, Libya, Qatar, Saudi Arabia, UAE, Jordan, and they are using different combinations of pertussis, acellular pertussis vaccines. So, as we said, the acellular pertussis vaccine are started to be used since 1990s. It is a great vaccine, very effective, much less adverse events than before, and better uptake, of course, because the pattern of adverse events are much different. However, we started to see more resurgence to appear with pertussis. And we started to see outbreaks here and there and all around the world actually, and we see them in our hospitals. So again, to the same slide we saw in the beginning, you could see here, we started to see increase in the baseline, and we see also outbreaks going on. And that started to be more appreciated after 1990s. And here is the question, what is this secondary to the resurgence of vaccines? The other issue that this resurgence, this is from the States, the resurgence is mostly seen where also in less than 1 year of age. It is seen in all age groups, but mostly in less than 1 year age group, and this is the red line. This is another notice that was made. And it's not just in the state. This is from the States, this is from Australia, this is the introduction, and these are the swings. This also from England and Wales. And if you could see, always, it is after 5 to 10 years from the starting of acellular pertussis vaccine. It takes this time to start seeing these resurgence outbreaks. So what's going on? Is it related to switch from whole cell to acellular? Or where is it happening? Is there an evolution of the bacterium itself, by genetically speaking, or is there a detection bias? These are some of the theories that are being stipulated in the literature. Or is there poor persistence of antibodies? In the next few slides, I'm going to try to look at these assumptions. So let's remember that the last 20 or 30 years, there is the revolution of PCR techniques, where you can make better diagnosis of many diseases, including pertussis, especially when we know that pertussis detection by the regular microbiological technique is difficult, at least. So, are we detecting more cases, or are we detecting of milder or atypical cases by PCR technique? There is no much evidence to support this concept, because it is not all true. There is real increase of severe diseases in infants. So we see outbreaks of real disease, not just because we are detecting by PCR mild or atypical cases. So now, what are the three stipulated mechanisms? Bacterial genetic evolution. Are we seeing bacterial genetic evolution? Are we seeing antigenic shift away from those covered by acellular pertussis? Or are we seeing overproduction of other antigenic targets? The one that we know for good, that now we have some isolates of pertussis that with deletion of antigens covered by acellular pertussis. If you remember, I told you there is an antigen called pertactin, which is in RP. There is now Bordetella pertussis with no PRN antigen production on the surface. They are increasing 10 to 25 years after switching to acellular pertussis. So we're seeing, and this is happening in the state, this is happening in Australia, and very high in Australia, up to 90% of the cases of Australia of a proven pertussis are without the PRN or pertactin antigen, which is covered by the acellular toxin. However, and in France, 15%. However, persistence, it is bacterial genetic evolution is not also so convincing. Because persistent efficacy in Sweden, they use a vaccine that doesn't have the pertactin antigen, the PRN, and still they see the new isolate without the PRN antigen. So it doesn't seem to be only a pressure of the vaccine itself. And resurgence timing is not synchronizing with accumulating of escaping genes. And the contribution of escaping mutants to resurgence is not well established. There is no synchrony. So still, even if you believe in this concept, it is not so convincing anymore. So the other question is the secondary to poor persistence of antibodies after being immunized by pertussis, acellular pertussis vaccines. Let's look at these mechanisms. Usually, if we have no vaccines, if we get the infection by natural disease, there is always 7 to 10 years of a protection. As we said at the beginning, there is no long life immunity secondary to pertussis vaccines. If we are getting only the whole cell vaccine, it's almost like natural infection, because you're getting just a killed bacteria. If you only use acellular pertussis, the protection is about 5 to 8 years instead of 7 to 10 years. And if you use longer and better, if you use the whole cell, followed by acellular pertussis, which is now a lot of talks about this being primed by whole cell and continued by acellular pertussis vaccines, it could be a longer and better, almost similar to no vaccine, a natural infection, than only with acellular pertussis. So these are the stipulated mechanisms. If so, then infection should hit older kids and adolescents. But it's not the case. We're seeing resurgence of diseases not only in adolescents, not only in adults, we see it also in infants that are there in the community. And the resurgence is happening along all age groups. So this is again is not very convincing mechanism. There is a proposed theory. Doesn't mean that I believe in it, but I just saw it. And it is now getting a lot of opponents and those who also with it. The theory says that acellular pertussis vaccines have relatively little effect on the transmission of pertussis. Defective, which means defective herd immunity and no effect on carriage. It's just like streptococcal pneumonia, the polysaccharide and conjugate pneumococcal vaccine. And I'll show you some evidence about this. The concept says if there is no vaccines, you will have outbreaks or disease. The amplitude here says that it talks about the number of diseases. And this is about the number of cycles, how often the cycle happens. If you get a vaccine that the whole cell, or a very nice vaccine, what you expect, that the amplitude of the disease will go down and the cycles will be prolonged because you are abolishing the carriage and you are having less episodic intervals of the disease. This is what you should get. However, and we have been learning a lot from the baboon models. This is certain studies that they look at the baboon models. This is a baboon that has no vaccine. This is another baboon who was primed with acellular pertussis vaccine, and this is another one who was primed by a whole cell vaccine, and they were sprayed by pertussis, Bordetella pertussis. This baboon developed the disease, clinically ill with lymphocytosis, as we accept her disease. And he was infectious for about 33 to 35 days. So it means that he carries the microorganism in his throat. While the whole cell vaccinee didn't develop disease, and he was infectious for about 18 days. So less disease and less infectivity for this baboon. This baboon who was infected, who was given the acellular pertussis vaccine, he did not develop the disease. So he has responded well to the vaccine. However, he continued to be infectious as much as no vaccines. So it seems by this theory that the acellular pertussis vaccine helps you against the disease, but it doesn't produce herd immunity as long as it is not affecting the carriage of the microorganism in the upper respiratory tract material. And this goes on. Again, different combinations, the same thing, that the carriage is not affected by the throat of this baboon. The other thing that supports this mechanism, that if you get the whole cell vaccine, you will get immunity, and we are being taught that by immunologists, by two mechanisms, by IL-6 and IL-12 mechanisms, B cells and neutrophils. If this is by whole cell vaccine, which is the same as wild infection. While giving the acellular pertussis vaccine will give you interleukin-6 specific immunity, but it will not get the other part, which is IL-12 here. So this is one of the mechanisms that support the carriage problem. So what are suggested strategies to prevent early infant mortality, which we are really concerned about? Booster doses in adolescents and adults, and this is practiced in several high-income countries. Immunization of newborn of infants, there is no enough data about that. Pertussis immunization in a pregnancy with acellular pertussis vaccine practiced in several high-income countries. Or cocooning mechanism, which is practiced in several high-income countries, which includes pregnant women and the household contacts together. And of course, you have to look at the cost effectiveness of this mechanism, or vaccination of health care workers. This is the concept of maternal immunization, which is the concept is simple, which means that at the time where you cannot give the babies the vaccine in the first few weeks of life, you can give the vaccine to moms in the second or the third trimester. It is preferably 2 weeks or 3 weeks before delivery. So you can protect the baby in the first few weeks of life when you cannot give the vaccine or you don't accept immunogenic vaccines at that time. However, I'm going to leave you here. I think we should look at the WHO position statements. The position statements, they are saying that there are increase in resurgence after acellular pertussis vaccines. They are not recommending changing from a system to a system. They are not doing that. They are refraining from going to that point. However, I mean, there's a lot of people saying now, if we want to use, let's prime with whole cell and continue with acellular pertussis vaccine. This subject will go on for debate, and I think we will see more information about this resurgence in the next few years. Thank you very much.